Okay, good morning, everyone. This is Drew Altman. I hope you can all hear me. Welcome to all of you. Thank you all for joining us. I'm told there are really a lot of you, and I appreciate that very much. We're going to be focusing on vaccine distribution from several angles at KFF. We'll be doing it through our analysis, through our polling, through our journalism, through our Greater Than AIDS program. So this is the first of what I expect to be many briefings that we will be doing on this subject. We have another web event on December 11th with our partners at the Undefeated and the Morehouse Medical School, where we will drill down more on issues of discrimination and racism and healthcare, and especially on COVID. And we'll be talking about vaccines then as well. And that event will include Dr. Nunez Smith, who's the co-chair of the Biden Advisory Committee. So we hope to see you again for that event. Just some housekeeping items. This event is being recorded. The slides will be posted. And most important of all, please submit your questions using the regular Zoom Q&A feature, and we will get to them after the very brief presentations, not too long from now. I do want to make some introductory comments just after months of, we're still in the middle of it, but after months of a raging pandemic, certainly the vaccine is a reason for all of us to be much more hopeful. But, and it's why we're here today, there are extreme implementation challenges ahead, and among them, just the sheer complexity of the effort and the challenge of vaccine hesitancy, especially in the Black community, where hesitancy is compounded by understandable, completely understandable distrust of government and institutions. And so we organized this briefing to focus on these implementation issues. I had a mentor when I was at grad school in MIT a long time ago named Jeffrey Pressman, Professor Pressman, of course we called him. He actually wrote the very first book on implementation. No one had ever studied it before. And basically the book said that the more steps and players and levels of government involved, the tougher it is. So I would just say that COVID vaccine distribution is implementation complexity on steroids. To me, the defining characteristic of the Trump administration's response to COVID has been leaving the COVID response. I suppose I would even say dumping the COVID response on the states. And the result has been extreme variation between the states and how they've responded to COVID. But it's also been this troubling, stark, red-blue partisan divide in how we've responded to COVID as well, which all of you on this Zoom call have witnessed. It's hard for me to see the Biden administration accepting 50 different state vaccination programs, but it's also true that the train is leaving the station before they take office. And so how they superimpose a new national plan on a state-based vaccination plan, that's a real challenge, and I'm sure it's something we'll be talking about today. Meanwhile, we're starting to see vaccine acceptance grow a little bit with more positive reports about the first vaccines. But the problem of vaccine hesitancy isn't going to go away. And there is a need for a substantial outreach effort that is credible in communities that need it the most. We've been operating large-scale HIV testing and treatment campaigns for decades. And there just is not enough discussion of the need for outreach and what it should look like. Not just the need for it, but what form it should take. And we may do a separate briefing on that in the future based on our experience. Among the things we're doing at KFF, one thing I would like to announce today is that we're launching a new initiative that we're calling the COVID Vaccine Monitor. We will be in the field almost constantly for the duration of this with new surveys and focus groups focusing on hesitancy and messages, which messages work, and messengers, which messengers are credible, but also on people's actual experience once the vaccine is rolled out, getting it. We hope this will be a resource for everyone involved in vaccine distribution and for all of you on this Zoom call. We also are going to be adapting as best we can our Greater Than AIDS campaign to include COVID information and COVID messaging. GTA is our multiple Emmy award-winning HIV outreach campaign that, among many things, works with state and local health departments across the country, but especially intensively in the South. So we've got several KFF experts who will speak about different dimensions of the challenge today. Let me tell you who they are, and then they can just follow one another without further introduction. But remember to please submit your questions using the Zoom Q&A feature. So Molly Brody, who's our Executive VP and heads our polling and survey research program, Molly's going to update you on what the polling data reveals about the public's willingness to get vaccinated. Jen Cates is our Senior Vice President who leads our global health and HIV work, is going to talk about the latest guidance from the federal government on vaccine distribution, what changes the Biden administration may bring to this. She's also going to talk about what the states are doing and what the states are not doing. I think many of you have seen our recent analysis of the first round of state plans on vaccination. Samantha Artiga is Vice President who leads our new program on race and health policy, and she's going to talk about ensuring equitable access, particularly given the disproportionate impact of the pandemic on people of color, which is something that we are truly focused on in our organization. And actually, before you hear from Samantha, you'll hear from Karen Schwartz, who's a senior fellow in our health reform program, and will focus on how government programs and also the private insurers would cover the vaccine. How's that going to work? And again, the focus for us is always on people. What are the potential costs to patients who will be getting the vaccine? So that's what we'll be doing incredibly briefly so that we can get to your questions, and we'll be starting with Molly Ann. That's your cue, Molly.
Got it. Hello, everyone. I hope this finds you and your families healthy and safe and well. We have been tracking the public's views, experience, and knowledge of all aspects of the pandemic since March, but perhaps nothing has been more front and center for us than this question of how people will react once the vaccine becomes available. What you see here is data across a number of pollsters. And it's a picture of how the public has reacted to the idea of a hypothetical COVID-19 vaccine. You notice that early on in the pandemic, large shares of the public reacted positively to taking a vaccine once available. But as the pandemic continued, and frankly, as the situation became more and more polarized and politicalized, you'll notice that fewer people were certain that they would take the vaccine. Now, what's particularly interesting is the one newest measure here, which is the Ipsos measure, 51%. They're the only people so far who've been in the field since Joe Biden won the presidential election and the announcement that the actual vaccine candidates had promising results in their trials. So we see for the first time since March, the direction of the willingness to get vaccinated has reversed from falling shares to increasing shares saying they are likely to get vaccinated. Now, this one chart illustrates points that we're particularly attuned to as this vaccine development and distribution stage continues. And we'll certainly be tracking in this COVID-19 vaccine monitor that Drew just described. First, there's a very big difference between the hypothetical and the actual. And so far, and for the most part, we've been asking people about their likely actions in a hypothetical situation. And second, largely because of that, this is going to be a dynamic environment, and the public's reactions will vary as the news of the day changes and as we start talking about actual vaccines reaching actual people and their success and their challenges in doing so. We expect that both overall views and the willingness to get vaccinated will change substantially as this narrative continues and the actual distribution of the vaccine begins on a large scale. So in this next slide, what we see here is that we've been paying close attention to the fact that willingness to get vaccine, or the opposite, vaccine hesitancy, is not consistent across all groups or all communities in the country. As you see on the left, Black adults remain especially skeptical and unwilling to say that they will get a COVID-19 vaccine. About half of Black adults told us that they probably or definitely would not get a vaccine, even if it was free and determined safe by scientists. Just 17% said that they would. In our work, we've seen long history of racial disparities and distrust of the healthcare system impacting Blacks' expectations and worries about taking a vaccine. And as Drew said, this is a community we plan to pay special attention to going forward. Now, you see on the right, Republicans are another group that is considerably less likely to say they'll get vaccinated. This stems largely from the political polarization that has accompanied the pandemic and reflects the partisan differences in information and focus that's been paid and placed on the virus. Now, as you can imagine, the reasons that each of these groups gives differ dramatically, and separate messaging and outreach strategies would be needed to reach each of these groups, as well as other critical segments that are vaccine hesitant, such as segments of the healthcare workers who also are expressing reluctance at this point in time. So, for example, in the next slide, note here that when we go the next step and ask people who are actually resistant to tell us in their own words what it is that they're worried about, Black adults are most likely to mention safety concerns, followed closely by distrust of the healthcare system and government. Whereas on the other hand, for white adults, but particularly those who identify as Republican, they're more likely to tell us that they just don't need it or they just don't want the vaccine. In the next slide, I think what we see is that part of what's going on here is the fact that large shares of the public are concerned about the politicalization surrounding the vaccine development process and whether it's being rushed for political purposes. While most of the public does trust the FDA to make sure that the COVID-19 vaccine is safe and effective, many people, Democrats in particular, as you see here in the dark blue, are worried about whether the FDA rushed the process under political pressure from the Trump administration. This is accompanied by other measures that are showing us real changes in trust of national public health messengers, places like the CDC and Dr. Anthony Fauci. Their levels of trust have declined over time and become increasingly partisan as well, with Republicans showing the largest drops in trust. And finally, in my final slide for the next one, I think what's going to become increasingly important, and certainly the main focus for today, is how are people going to actually see the distribution process itself? Are they going to think it's fair, efficient, working well? Do they understand where they sit in line, so to speak? Will they agree with that? So far, there's only been limited polling on all this, but note here that just about half of the public said that they are confident that when a vaccine becomes available, it will be distributed in a way that is fair. Many fewer Black adults agree. In fact, a large share, about 2/3, told us that they were not at all confident about this. So as the vaccine distribution process begins in earnest, I expect to see that views are going to move and evolve as more information becomes available. But the way that that information is communicated and the chosen messengers for that communication is going to be critical in determining whether levels of trust can be reestablished and whether currently reluctant Americans will ultimately decide to get themselves vaccinated. Thank you, and I'm turning it over to Jen. Your turn.
Thanks, Molly, and hi, everyone. I'm going to hit on a few big picture issues, and all of which we've addressed in various reports. I'm going to talk a little bit about some key challenges overall, a little bit about where the states are from our review, cover the latest guidance from CDC and what we know is likely to happen, and then just forecast a little bit about what we might expect from a Biden administration going forward. So we looked at, this is a report we did on key issues and challenges for COVID vaccine distribution. And obviously we can't cover all of these in detail, so we have a report on it that you can look at. But just to hit on a few, on the funding side, I think this is really important to understand. There has been very little funding provided directly to states for vaccine distribution. The federal government is paying for the vaccine, has obviously funded a lot of the R&D, but in terms of getting the money to states for preparing for the kinds of things that we're going to be talking about today, very little has been provided. It's been about $200 million to date. And with the COVID stimulus discussions on the Hill sort of at a stalemate, that's an open question right now if there will be additional funding. Both the Republicans and the Democrats support additional funding for vaccine distribution, so that's not a sticking point. It's just getting caught up in the overall stalemate on the Hill and with the administration. Another big issue, and I'm not going to go into all the details here, but is on the supply, logistics, and monitoring. And you cannot focus on that enough. It's just going to be an unprecedented effort that the states especially are going to be asked to take on at a level that they've never done before. This is very different than routine vaccination, and there's many things about the vaccines themselves that are quite different. Another issue that we looked at is the different roles that the federal government will play, the states and local authorities. In general, public health is under the authority of state governments, as is happening now. However, when there is a pandemic, there are other things that come into play. As we know, viruses don't respect state boundaries. They don't care what state laws are. And that's just not how this is going to play out. So how that balance gets worked out between the federal government and the states, I think, is going to be a defining issue of the vaccine rollout. We also looked at issues around insurance coverage and out-of-pocket costs, which Karen is going to cover. And we looked at issues of, to the extent that addressing racial and ethnic disparities is or is not done will make or break this rollout. And Samantha is going to talk about that. And then lastly, of course, communication and trust, which Molly already covered. Next slide. We also looked at states and where they are in planning, and states were asked by CDC and HHS to submit preliminary plans. We looked at those plans that were submitted mid-October, so this is already a little out of date. And we just wanted to see where they were, and in general, they were all over the map. As expected, states have been hard hit by COVID. It's affected their populations, their economy. They have not gotten as much support as they say they need, and they've been really struggling just to manage and let alone take on this added unprecedented planning for a vaccine. They've also been underfunded historically for preparedness, and we're now seeing what that means. In our look at the plans, while they were preliminary, we did notice some things. I'll just highlight a few trends. Less than half were able to, or at least did provide a numerical estimate of the number of individuals in the priority populations that will likely be eligible for a vaccine. Most said they were still trying to develop those estimates. Less than a third were able to or did provide an estimate of how many vaccine providers were in their states. And we know that that's going to be critical because states are going to have to ramp that up. So they need to know who the vaccine providers are now, where they are, and how many more they need. About half were able to report an estimate of the number of providers already in their immunization registries, and many just were in the beginning stages of developing or making those registries and the systems that they'll need from a data perspective robust enough to manage this rollout. Lastly, on the communication side, states are being asked to plan for campaigns. They were in their infancy for the most part. What happens next? Next slide, please. So what is actually going to happen? I think most critically this week, the CDC's Advisory Committee on Immunizations provided its initial recommendation, which was adopted the next day by the CDC director, which is when and if a COVID vaccine is authorized by the FDA and recommended by ACIP, it should be offered to healthcare personnel and residents of long-term care facilities. That's the recommendation. We expect most states will follow it, but states ultimately will make the decisions. The FDA has its own advisory committee meetings scheduled on the 10th and 17th to review the two vaccine candidates for which an emergency authorization has been requested. If it's approved, we've been told the vaccine will be expected in 24 to 48 hours. What does that mean? A question we keep getting asked: how many doses? The federal government says there will be about a little over 6 million for the first initial distribution, and that could ramp up to 40 million doses by the end of the month. That's 20 million people. That may happen. That's optimistic. It all depends on a lot of factors. These are going to be distributed based on the state's share of the adult population. And that's really important because we know, while that's fair on many levels, it's very transparent. States understand it. We understand it. States can plan. We know that priority populations are not distributed evenly across the country. So this will be something to watch. And then finally, there is going to be some centralized distribution of the vaccine, but there's also going to be direct distribution. And depending on the vaccine, this will vary. And then finally, just to say again, this is a massive effort. And right now we have 51 plus different vaccine plans, 51 plus. So ultimately what we see, hopefully what we will not see, is that who gets the vaccine depends on their geography. Last slide. We've looked a lot at the differences between the Trump approach to COVID and the Biden likely approach, and just a few points that I think we can expect from a Biden administration. There will likely be a much heavier federal hand going forward in thinking through and planning on the vaccine front. I think the federal government thus far has been pretty strong on vaccines, but there's going to be a need for very, very clear messaging on a regular basis to the American public about what the vaccines mean and what they don't mean and how important they are. And then finally, I would expect a Biden administration to play a much bigger role in ensuring equity of the distribution of the vaccine across states and within states to ensure that populations who need the vaccine are getting that vaccine. Without that assurance, I think we could see the 51 plus plans become a real story about access and a lack of access depending upon where people live. Thanks. And now I think I'm turning this over to Karen.
Thanks, Jen. So few things in health policy are simple, but in the case of the COVID-19 vaccine, there is a very simple take-home message, which is that no one going to get the vaccine will be charged for the vaccine or its administration, no matter what type of insurance they have or whether they have insurance at all. And that's for two main reasons. First is that, as Jen mentioned earlier, the government has already paid for these initial doses of the vaccine, and those doses will be provided for free to providers who are then not allowed to turn around and charge for the vaccines that they got for free, although providers are allowed to charge for vaccine administration. And the second is that some of the usual rules that govern vaccine coverage for people with insurance have been strengthened for the COVID-19 vaccine. And I'll go through those now. So first, for people with private insurance, the Affordable Care Act requires coverage of preventive services with no cost sharing, and this includes recommended vaccines. In the case of the COVID-19 vaccine, they added some additional protections, namely that for folks getting the vaccine from an out-of-network provider, which may happen given that there may not be a lot of choice about where to go get that vaccine, that the insurer will have to pick up the cost of the vaccine administration from the out-of-network provider. And there's limits on what those providers can charge, and they're not allowed to turn around and balance bill people for getting the vaccine out of network. In Medicare, it's relatively simple. The vaccine will be covered under Medicare Part B as in boy, with no cost sharing. In Medicaid, during this public health emergency, states are required to cover the COVID-19 vaccine as well as any COVID-19 treatments for all beneficiaries with no cost sharing. That requirement would end soon after the public health emergency ends. And for people who are uninsured, they would be able to go to any provider who's gotten this vaccine for free from the government and get the vaccine. They can't be turned away or charged anything for the vaccine or vaccine administration. Those providers will be able to bill HHS for vaccine administration and be reimbursed that way. I think it'll be very important to educate everyone, but particularly those who are uninsured, so that they'll know they can go anywhere where the vaccine's available and get the vaccine as soon as they qualify to go get it. That some of the barriers they would typically face with, say, a flu vaccine or another vaccine in terms of cost won't be there for the COVID-19 vaccine. And so with that, I will turn it over to Samantha.
Thanks so much. As all the speakers have alluded to so far, as these vaccine distribution plans continue to develop, one overarching issue to consider is really how to ensure equitable access, particularly for people of color. As you can see in the data presented here, as well as a continually growing body of research, we know that the COVID-19 pandemic is taking a heavy, disproportionate health and economic toll on people of color. As such, preventing racial disparities in uptake of the vaccine is going to be key for mitigating these disparate impacts, as well as preventing a further widening of these disparities going forward. Moreover, ensuring everyone has access and is able to get vaccinated is going to be key for achieving the levels of vaccination needed for overall population immunity. Next slide, please. So we know that data from existing vaccines show people of color are less likely to be vaccinated compared to their white counterparts. For example, as shown in the data presented here, less than 4 in 10 Black, Hispanic, and American Indian and Alaska Native adults received the flu vaccine compared to nearly half of white adults. Next slide, please. The lower rates of vaccination among people of color really reflect a range of barriers to vaccination that disproportionately affect people of color. These include access-related barriers, such as higher uninsured rates, as shown in the data presented here, as well as other access-related barriers, such as lack of a usual source of care and/or difficulty accessing providers. Next slide, please. But beyond those access-related barriers, both historic and ongoing racism and discrimination also create barriers to vaccination for people of color. As Molly noted in her remarks, really the primary concerns we see expressed by Black people about getting a vaccine are safety and distrust of the government and the healthcare system. These findings really reflect the long history of the medical system's abuse and mistreatment of people of color, particularly Black Americans. But I think it's also really important to recognize that they also reflect ongoing discrimination occurring in the healthcare system today. For example, as shown in the data presented here, which come from that same recent survey from which Molly presented results, we see that Black adults were more likely than white adults to report certain negative experiences receiving healthcare, including a provider not believing they were telling the truth, feeling they were that a provider refused to order a test or treatment that they thought they needed, as well as a provider refusing to prescribe pain medication that they thought they needed. Next slide, please. So in developing guidelines for vaccine allocation, we've seen that the National Academy of Medicine, as well as CDC's Advisory Committee for Immunization Practices, have emphasized the importance of equitable allocation, particularly for mitigating these disparities. To date, when we look across the state plans in the analysis that Jen referenced in her comments, we see that the extent to which states are focusing on racial equity really varies. Some are incorporating and have noted racial equity will be a priority as part of their plans for distribution and allocation. Fewer have detailed how they are going to be sure that they include providers in their networks that are necessary to reach diverse populations, as well as detailing how they plan to have their communications plans reach those diverse populations as well. As we really look ahead for prioritizing equity, it's going to be key to facilitate access. That means making it really easily accessible to people in terms of the locations where the vaccine is, as well as the modes of access. Not everyone is going to be able to access, for example, through a drive-up option. So we need to have multiple modes of access available. Also considerations related to the hours at which people can access that reflect different work schedules as well. As Karen noted, it's going to be really important to also make sure that people know that the vaccine is available at no cost to prevent any of those cost-related barriers that are particularly likely around, among uninsured people. But beyond those access-related barriers, as Drew noted in his opening, really, I don't think we can understate the importance of outreach and education and making sure that it is effective outreach and education. And that really is going to mean that systems and providers are going to have to really proactively work to earn trust and address safety concerns in a way that acknowledges the historic racism and discrimination, as well as the ongoing discrimination we see in the healthcare system today. It also is going to really hinge on utilizing trusted messengers with shared backgrounds and experiences of the people that you're trying to reach, as well as ensuring that the materials are presented and provided in ways that are linguistically and culturally appropriate. And with that, I'll stop and turn it back over to Drew.
Drew, you're on mute.
Am I back? Congratulations to me. Was trying to say, I don't know what's better, the presentations or the questions we're getting, because we're getting amazing questions. It's a moving list and I've lost one of them from the list, but I remember it. And it was, what's important for reaching in particular the Black community besides credible messengers? I'll start on that one, and then I want to turn it over to Jen. I have a question for Jen about that, which is, it is more than just messengers. I mean, one of the things we've learned in our Greater Than AIDS campaign over decades, it is about mobilizing community-based organizations, but it is also about targeted media, which these days, and I really mean targeted, which these days means digital media. Mostly it does not mean PSAs. And there's lots more to be said about that. But all of that also means funding. And I haven't heard any really discussion of this, including of the funding. So let me start with a question for Jen. We also have Josh Michaud here somewhere if he wants to jump in, but has there been any discussion of outreach, and in particular of the need for funding for outreach?
I would say that in general, the funding discussion has been high at a different level than that. And that may be one of the things that's been talked about. And I certainly know group advocacy groups have raised it. But in general, states have just been saying, we just need funding for vaccine distribution for the whole package, whether that's, setting up our data systems, doing campaigns to do outreach. As Samantha said, some states are really thinking hard about how to reach communities who are disadvantaged. Some states are not. But that in our view, it would be a key part of this. The problem is as I mentioned, there's been very little funding provided to states at all. And I think that's going to be a real limiting factor in their ability to go forward. While we know how important communication is going to be, my guess is states are going to be focusing first on the cold chain storage issues and the staff and the vaccinators that they need and transporting and monitoring second doses, and less on what we know will make or break this, which is reaching people and getting their attitudes to be receptive.
Yeah, I don't want to make this a dialogue between us, but that was the reason for my question. And states have done a reasonably good job with campaigns on opioids, on smoking. It's one of the areas in which states can play a constructive role and also as a conduit for funding. There are other areas where they've been less successful. All right, let's move on to a different question. Let me see, I'll use just first names. So this is a question from Catherine. The question is, what criteria will be used to identify people under 65 who have underlying medical conditions that make them eligible to receive the vaccine earlier? And how would they get the vaccine, which is really a separate question of interest, through their physician's office, drugstores. But this is something I've actually also wondered about, really how would we go about identifying people in a fair way with pre-existing conditions? I don't know if that's a question for Jen. It might be.
I can start. Maybe Josh can jump in. This is, first of all, no guidance has been provided on this to states or providers yet. It's been a topic that's come up at the CDC's advisory committee. And from what I understand, it's likely that this is going to be a combination of potentially self-disclosure by individuals, as well as a combination of their providers having information. I think it's very murky, and we could get in a situation where if it's not clearly defined, we have a complete, variation across the country or even within a city of who is getting vaccine and who isn't, even if they have the same underlying health condition. So this is going to be a very vexing area. I don't know, Josh, if you have any other thoughts about that, but that's my understanding.
No, thanks, Jen. You said it, I think, perfectly. There really isn't a lot of information about how this will actually happen. We can speculate that, at some point, private providers, so doctors' offices, will be involved in actually administering vaccines to people, and they would have access to records which allow them to discern whether someone meets the criteria for high-risk condition or whatever it is. But when you're talking about going to the CVS or going to other distribution points, how are you going to prove that you fit into those categories? And I don't think that's quite clear yet.
Okay, I think this is a real challenge. Here's an interesting question. This is from Dana, and it will be a question for Molly. And the question is, what's the deal with the Republican reluctance to get the vaccine? What is behind all that?
Yeah, it's a good question. At this point, what we're hearing is mostly that there's just not a sense of a need. That in general, in all of our measures, we've seen that Republicans have more likely thought that the virus was not as big a deal as Democrats have. And this is a rare public health case where polarization and politicalization has really become another demographic in terms of having to think about different messages and different audiences. And so, the pandemic played out very differently across the country, but more importantly, the pandemic played out in terms of the information and the conversations very differently across the country, whether it be a red state or a blue state. A lot of that came from, different messages from leadership. And so, what many Republicans took away from is that the COVID virus itself isn't that dangerous, and that they don't actually feel that they are particularly at risk for getting it, and that they don't necessarily want to, be vaccinated. Now, again, we will see how all that changes as information changes, and certainly as we've seen these surges across the country affect more and more people, that it may be more and more the case that we more universally will have known somebody who has been badly and sick and infected in a way that heightens their concern about the COVID virus. The other thing I'd say is that we know that there's a real relationship between misinformation about things like protective messages like masks. So we know that those who don't think masks are helpful or useful, or don't believe in the use of masks, are also not interested in getting vaccinated. And all of this information has tended to go along with political party identification, at least to date.
Yeah, and as Trump fades from the scene and Republican governors feel a little more free to do whatever they choose to do, does that change things somewhat? We'll see. All right, here's an important question. It is from an anonymous attendee. I hope that doesn't reflect personal concern, but it might. It's a question for Samantha, and the question is, will citizenship or residency status be considered in the administration of the vaccine? Might those of particularly Hispanic background fear getting a vaccine for fear of residency status?
So Karen might be able to jump in related to some of the issues related to coverage and avenues for accessing the vaccine. I will say one issue that I will raise is particularly because most of the top vaccine candidates right now are a 2-dose vaccine. There will be information that will need to be tracked to monitor who has gotten the vaccine, including identifiable information. And so I think it's going to be really important to think about how that information is collected and what is shared with individuals about where that information is stored, what it can be used for, and who it can be shared with, to help reduce potential concerns, particularly among the immigrant community, about having to share information in order to access the vaccine. We know in particular that over the past few years, given the shifting immigration policy climate, really there has been an overall increase in levels of fear and uncertainty among immigrant families that have made them increasingly reluctant to access services and programs, and in particular to share any information with government programs as well. So that is going to be something that's going to be really important to think about going forward, again, as part of the outreach and messaging associated with accessing the vaccine. But Karen, I don't know if you want to talk a little bit about rules related to access through coverage.
Sure. I mean, I'll just say everything I said about the vaccine being provided for free and uninsured people being able to get the vaccine from any provider is also true regardless of immigration status. But it will be very important to make sure people understand that they can go anywhere and get the vaccine, providers can get reimbursed by HHS for providing the vaccine. And that's also true regardless of the immigration status of whoever received the vaccine.
So Karen, while you're up, I've got questions about what about future doses and cost sharing? What about people covered under short-term plans or health sharing ministries? Same answers or different answers?
So for these initial doses paid for by the government, if you're in a health plan, say a short-term plan that doesn't cover vaccines, you'd effectively be uninsured, but similar to other people who are uninsured, you'd be able to go get the vaccine anywhere and wouldn't be charged for that vaccine. That requirement is for these doses paid for by the government. If eventually this becomes an annual vaccine and the public health emergency ends and it's sort of like a flu shot where we go every year to get our COVID-19 vaccine and it's no longer being paid for by the government, then those protections would no longer be there. I don't know, Jen or Josh, if you want to chime in about, when that shift may happen, if we know anything there.
I would just say that, the government has purchased several hundred million doses across multiple vaccine candidates. So part of this will be which candidates we know which are likely to be first out of the gate, but then what continues to happen, how it doesn't reach everybody that needs to be reached because there might not be enough doses of the right vaccine. And then to the extent that this is still a pandemic, the government would probably be in the position of needing to purchase more. When it would become more of a routine situation is when we no longer have a pandemic and there's no community spread. It's just a community spread at the level of like annual flu. Then it would revert to our regular immunization system and reimbursement. All of the reimbursement issues that exist with that will exist with a COVID vaccine.
Okay. So many great questions. Here's one I have a personal interest in. What are the obligations of employers? And what might employers do, particularly in response to the vaccine? I think that probably should include comments on employers who make a vaccine mandatory as a condition of coming to work.
So from what I understand, this is going to be an issue. I'm sure there are going to be employers who want to do this. I believe the EEOC and other arms of the federal government that look at these kinds of issues have put out guidance that suggests, not about COVID specifically, but that employers can mandate vaccination, but they have to provide opt-out options for their employees in particular circumstances. There are, I think, exceptions to that when you're talking about maybe healthcare workers, but in general, that's going to be interesting terrain because I imagine there'll be court cases related to this coming up. I don't know if Karen has other, or I don't know if you've seen other things on this, but yeah.
This is Molly. I would just add that I think employers are going to be one of many important messengers on a vaccine, especially when we get to a stage where it's more generally available and generally distributed. I think, employers are eager to get their populations vaccinated and back at work and in their offices and, and keeping them safe. So I think that there is going to be a very important role. And I know that there are some employer groups right now working at thinking through how they can do that effectively and be, trusted communicators with their staff about the vaccine as it becomes more available and as more information is available. I mean, one thing to just say, there was positive news from the first sets of trials, but there's a lot of unknowns still. And so we're all operating in a world where everyone still has way more questions than there is answers to. And I think employers are in the same place at the moment.
We have a number of important questions about the disability population. So that's just to tee up that as a general subject, but I'll read you one question, a good question from Kara. She says, are any states considering the disability population when prioritizing equity? It would seem we've learned this lesson from the problems with crisis care plans in the past. It also raises the question to me of any potential differences between CDC priority recommendations and state priorities. I suppose we're back with Jen and Josh.
Sure. On the first, I don't recall seeing that level of specificity in any of the state plans that when we looked at them around prioritization, they were really, it's possible that a couple of them mentioned it, but there was nothing really addressing this. That does not mean that some states won't, but I have not heard that as elevated in the conversation to the extent it needs to be. I would agree with that question. The second question was around, will we see a difference between the ACIP recommendation and what states do? Potentially, I mean, states, this is a recommendation. States are expected to, and all have said they're waiting for this recommendation, but and states are, I think, putting forward a really good effort to base the recommendation on science and public health. But we cannot say for sure that every state plan will prioritize exactly what ACIP says. And then ACIP did not make a distinction between long-term care residents and healthcare workers in terms of shares and how to make that decision or within those populations. So we are going to see differences anyway, but I would bet most states will come in with those as their first two sets of priority groups.
Okay, we have a number of questions about the homeless, both about the need, but also in the risks, but also about any special arrangements that may be being thought of to provide the vaccine to the homeless. That may be the same answer as Jen just gave, but I don't know, Samantha has done a tremendous amount of work on the homeless population. I don't know if you want to take that on or Jen does.
I'll look to Jen and Josh to the extent they saw any of that indicated in the plans. I bet it's likely the same answer as the previous one in terms of them not really drilling down to that level of specificity. I will say it's a great issue to raise. We have done some work, as you've mentioned, focused on some of the specific challenges and needs among people who are experiencing homelessness. And it's clear that the pandemic has really presented significant challenges for that population in terms of the risk of exposure, in terms of challenges in terms of their ability to protect themselves, in access to water, to wash and follow public health practices. So it certainly is a population that's facing specific and unique needs, and again, speaks to the importance of developing really targeted and tailored efforts to reach out to and connect with the varied populations that states will be trying to reach, and designing efforts that address their specific needs.
Okay. We have a couple of questions about the role that pharmacies may play in distribution.
Let Josh start with that one.
Okay, sure. Yeah, pharmacies are going to play a huge role in the distribution, best we can tell. So the federal government has a partnership program that they've announced with pharmacy chains, which will take a couple of different forms. So there is a partnership with CVS and Walgreens and maybe some other pharmacies, I'm not sure, that will be heavily involved in vaccinating the populations in long-term care facilities. And those groups, of course, are in the highest of the priority populations that are recommended by ACIP and which most states are prioritizing. So the pharmacy staff will be receiving the vaccines and will be responsible for providing the vaccines in these facilities in many cases. There will be in the future, as the net of the number of doses grows and the net of vaccination grows beyond just those early priority populations, pharmacies will play an important role in administering vaccines to other populations as well. And there is another federal partnership with pharmacies saying they'll distribute directly to those pharmacies so that they can be provided and administered in those pharmacies. Then there are other smaller pharmacies that states will be involving in the distribution as part of their enrollment for providers process, they're going to have to reach out to those pharmacies, enroll them as COVID-19 vaccine providers, and could be an important point of distribution as well. The stage has been set by changes in federal guidance allowing pharmacists to administer these vaccines in places where they hadn't maybe been able to, as long as they meet certain requirements and have been trained to do so. So yeah, pharmacies are going to be an important part of this. And there's even discussion of expanding to other distribution points that you might not think of, dentists and optometrists and things like that. But those haven't been fully formed in the policies yet that I've seen.
Lori asked a question, where can I get data on my own state's preparedness and my own state's plan?
We have all the plans that are available on our website. We have a report on this and a link to the plans that were available. And we looked at them, some of which have been updated. So if you're having trouble finding that, just reach out to one of our communications folks and we can get it to you.
All right, we've done a tremendous amount of work on long-term care facilities. Others have done great work too. And here is an interesting question. How will long-term care facilities, this is from Carol, who may need on-site vaccinations, get access? Is someone going to actually go to those facilities to administer vaccinations?
I'm happy to start with that. One of the things the federal government did that I think is going to really help in this regard is launch a federal pharmacy partnership program with CVS and Walgreens, and it was an opt-in program for long-term care facilities. The advantage of them opting in, and it's really for the initial phase, was that the CVS and Walgreens would commit to providing the vaccine to the facility and administering the vaccine and reporting the data needed to be reported, and managing the cold chain and basically the whole process. As I understand it, 99% of facilities have enrolled in that. And so it is one area where I think that part will potentially be more uniform, since they will have a system in place to provide it. There's one wrinkle, which is that if a long-term care facility is located further out than 75 miles from a pharmacy, they're not guaranteed to be able to use that program. So to the extent there are really remote ones, that could be a barrier. But there is a system in place to at least address that.
Yeah.
And it's free to the facility.
Right. Here's a question. Is there a precedent? This is from Kathleen. Is there a precedent or a role for foundation funding to states to fill the gap in federal funding until the Biden administration is in place? I'll take that one. First of all, I hope everyone knows we're not a foundation, even though we have the word in our name. We're an endowed nonprofit organization. There is a long history of some foundations directly funding state government to do stuff. It isn't usually to provide services, because foundations don't have enough money to do that. It's more typically to support demonstration programs or help states get things off the ground or fund research or small little staff groups. But yes, absolutely, foundations can help with that. There are not a lot of foundations at the state and local level interested in getting that directly involved with government, but there are some, and increasingly there are foundations. So I'm guessing maybe this person is directly involved in this area, and it is something to look into. But don't be under the illusion that foundations can fill this kind of a funding gap. The money involved is just too big, and so ultimately it has to come from government. Okay, here's a factual question, but there are a lot of things which are not well understood, so I'll put it on the table. But it's from an anonymous attendee. Most vaccines are listed as 2 shots. What is the time frame from the first shot to the second shot? Why don't we also throw in how long it takes after the second shot before people are thought to be protected?
I can take that. So the 2 vaccines which are currently under consideration for authorization, the Pfizer vaccine and the Moderna vaccine, have different timetables for the second shot. So for Pfizer, it's 21 days after the first shot, you get the second shot. And then 7 days after that is when you're supposed to have achieved the immunity level. And with the Moderna vaccine, it's 28 days. And I believe it's 7 days after, though I haven't seen that specifically. But yeah, that's the that's the timeline for the second shots on both of those vaccines. The other vaccines which are in the pipeline, you know, there may be different schedules on those, but I don't think we know those yet.
Okay. Okay, we're almost at the end. Let's do this. The 1, 2, 3, 4, 5 of you have all had severe time limits imposed on you today. Are there any closing comments that you're just dying to make for the group here today?
I'd like to make one, and that's that we really recognize that hesitancy in this case is a very valid response. There's, as I said before, there's so much uncertainty and there's so much that's not known that I don't, this is not the same as when we talk about anti-vaxxers who have, you know, very specific reactions about vaccines more generally. In most of these cases, we're talking about Americans who generally get a flu vaccine. They often, you know, get all their other vaccines, but there is so much uncertainty at this point in time that they are hesitant. And I think in many cases, appropriately hesitant about whether they want to be first in line for this vaccine. And I think that as we are talking about communication and about outreach to groups, I think everybody needs to keep that in mind in thinking about the audience, that just because you're hesitant doesn't mean anything about your general sense of value about vaccines or about your concern about COVID or about your concern or about what it means for your life. That at this point in time, hesitancy may be actually the right answer for many people. And so I just want to say.
I'll just add to that, you know, I work in global health and pandemics and thinking about all these things. And there's never been a situation where the entire country, let alone the world, has been directly affected by something like this at such an intense level. And the scientific enterprise and endeavor has played out on the public stage in the way that it has, and politics has been so visible in that. So just to pick up on Molly's point, I mean, we don't have easy lessons to look back on to give us answers. But having said that, I'm optimistic because the vaccines showed very good trial results, and I think we should remember that.
I just add that the dosing, manufacturing, and distribution schedule that Operation Warp Speed has laid out is incredibly ambitious. They're talking about 100 million people that may be able to be vaccinated by March. That implies that states will have to get a lot of their logistical and other aspects of their plans in order in a hurry. So the time window here is quite short. So I know there's progress been made since we reviewed the plans a few weeks ago, but you know, there's a lot more to do to address all of the various issues that have been raised here today, and particularly the equity concerns. Without having a robust communications and thought out plan to reach those populations, it's going to be very, very difficult to achieve adequate equity across vaccinations in the priority populations, and thinking essential workers and those who are at high risk. So yeah, there's a lot to do in a short amount of time to do it.
I would just again echo what everyone's saying here, as well as I mentioned in the comments, that we cannot, I think, ignore the importance of getting the outreach and messaging right, and that it's really going to require multiple levels of outreach and communication. So both the mass media type efforts, as well as more of the local level grassroots efforts, that those communications really need to be tailored specific to the audience that you're trying to reach, in a way that, to Molly's point, really respects and acknowledges the experiences that they are coming with and sort of meets them where they are in terms of their perspectives on the vaccine.
And I'll just add in terms of coverage, we've seen some challenges in people being faced with high bills for COVID-19 testing. I think the protections are a lot stronger here, so I'm not anticipating some of the issues we've seen, but I think for the general public, they may still be nervous, oh, I had a neighbor who got socked with this huge bill. I don't want to go, that's just another reason they may be hesitant to get that vaccine, and another thing that we're going to have to educate people about.
Okay, thank you very much. Let me just close off with a couple of comments, because as you can tell, I'm losing my voice. But first, just to remind everyone of the obvious, and many of you have inside comments, which is we're still in the middle of one hell of a crisis. And so we've got a lot of work cut out for us on every front. We're telling the stories at KHN of every frontline health worker who has lost their lives. And it just underscores the crisis that's still unfolding all across the country now. There are no hotspots. The whole country is a hotspot. So that's the first thing. Second thing is we are totally committed at KFF to providing as much critical information and facts as we can. Our role remains the same, even with all the changes. It's providing the facts and the information and holding government accountable, whether it's the Trump administration or whether it's the Biden administration, and we will continue to do that. Thirdly, some of the things I mentioned today are really significant undertakings. Launching this new COVID vaccine monitor is a very intensive effort with surveys and focus groups in the field all the time, as long as we are implementing, the country is distributing the vaccine, focusing on all the issues we have discussed today. So we will be doing that, and I hope you will be following that. And we intend to have a dashboard up where you can find all the information from that just as soon as we can get it going. And then finally, remember the event I mentioned with Morehouse and the Undefeated on the 11th, focusing on the equity issues and the issues of racial justice that have been interwoven throughout this entire discussion. So with that, there have been so many of you here today, which just reflects the commitment to all these issues. I think we have a shared commitment to all these issues. So thank you for attending, and hopefully we'll see you soon for the next briefing. Thank you all very much.